Hi everyone, I am Shumon Kantide and I am excited to present our work titled Beyond the Rubric Cultural Misalignment in LLM Benchmarks for Sexual and Reproductive Health. This work is a collaborative effort among Emory University, the Hoover Institution, Stanford University, and Maina Mahila Foundation, a Mumbai based NGO in India focused on women's health and empowerment. Our motivation stems from the global disparities in sexual and reproductive health or SRH access, especially in low resource areas where cultural barriers and limited resources hinder information availability. And as more organizations start turning to LLMs to fill these gaps, we notice that there are very few benchmarks designed for such kind of topics or for the communities that need them most. Most existing benchmarks are heavily English centric, do not reflect the cultural diversity required for accurate SRH evaluations. For regions like India, HRS responses must be context specific and English-based benchmark often fail to capture this nuance. This is why region-aware and culturally sensitive evaluation approaches are so important. In this study, we try to explore two research questions. First, we looked at how existing health benchmarks fail to capture the cultural nuances of SRS questions and misinterpret or penalize responses that are actually accurate and context appropriate for low resource setting. Then we explore what modification or region-aware extensions are needed so that SRS models can be evaluated fairly across diverse cultural and linguistic contexts. In order to understand how global and English-centric healthcare benchmark overlook culturally grounded SRH answers, we used Mainabolo, an LLM-based chatbot developed by our partnered organizations Maina Mahila Foundations. Through this collaboration, we aim to explore how Mainabolo provides localized and culturally sensitive SRH guidance for women in underserved communities in Mumbai, India, and how current benchmark fail to evaluate such context-specific response accurately. As we discussed in the motivations, many healthcare benchmarks are evaluated in English and reflect Western medical norms which can undervalue culturally grounded SRH advice. And to answer the research questions and evaluate the efficiency of Mainabolo, we choose HealthBench, created by OpenAI, one of the most comprehensive framework that covers a wide range of health domains, including SRH, which is missing in many other benchmarks. HealthBench includes 5,000 questions across 7 key health domains, offering detailed physician-written rubrics to test whether a model can provide safe, accurate, and context-appropriate guidance across a wide range of health situations. For our study, we first needed to extract all the sexual and reproductive health questions from HealthBench. To do this, we used GPT-4 to run the SRS filtering prompt you can see on the slide. The prompt included core SRS themes, which helped us identify 637 SRS questions from the dataset, where we can see about half were singleton and half were multiton. Since our goal was to examine baseline model behavior, we focused only on the singleton set. Mainabolo responded to about 3/4 of this, which is about 244 out of 330. The rest were outside the intended scope of the model, such as region-specific inquiries and highly technical medical codes. Then two human reviewers, one had a formal public health background, and while the other has received SRS training, performed qualitative analysis of low score responses. This slide gives an overview of our key findings. We found that health bans often penalize culturally grounded responses. For example, breastfeeding loss. It sometimes misjudges region-specific advice like dietary recommendations or local norms. It also tends to favor long technical responses that do not align with real users needed for a concise answer. Additionally, HealthBench reflects a healthcare provider perspective which misses the patient's voice in SRS discussions. Finally, ambiguity in some queries lead to misinterpretation, affecting the evaluation of the models. In the next slide, I will explain 3 cases in more details. In the first example, the user asked about breastfeeding laws in public. Mainabolo answered in a very culturally grounded way and recognizing that India has no legal prohibitions and acknowledging general acceptance and offering practical guidance like using a shawl or dupatta, which means a long scrap or cloth used to cover the upper body for privacy. This is exactly what a local user would expect. But the health bench rubrics required mentioning US breastfeeding protections, even though they have no relevance to Indian mother. As a result, the response were penalized despite giving a correct contextual appropriate answer. This clearly shows how Western centered criteria can misjudge and undervalue regionally accurate responses. In another case, the user asked which fish are safe to eat during pregnancy. Moinavolo answered using fish that Indian women actually consume, ruhu, katla, pomfret, and emphasized cooking thoroughly to reduce infection risk. This is a medically sound advice and aligned with local diet patterns. However, the health bench rubric expected a list of fish commonly found in US supermarket. Because of that Western assumption, the response was penalized even though it was appropriate for an Indian context. This illustrates how dietary norms embedded in a benchmark can lead to unfair evaluation of culturally grounded SRH guidance. We have also found bias towards US prescriptions for postpartum depressions. The user is 2 weeks after delivery and feeling depressed and overwhelmed. Mainabolu responded gently and safely, suggesting emotional support, herbal and home remedies, relaxation strategies, and advising her to see a doctor. This is intentional because the chatbot is designed not to diagnose or prescribe medication, but the Hellman rubric expected the model to mention a specific US prescriptions antidepressants like sertraline, brexanolone, and zoranolone. These drugs are not accessible with a prescription in India and should not be recommended by a chatbot. So even though Mainavolo gave a safer and culturally aligned responses, it was penalized because the rubrics assumes US medication norms that do not apply to our users. We also want to mention 2 additional key findings. First, with the period delay questions, Mainavolo used respectful and privacy-preserving phrasing if there is a chance, instead of assuming sexual activity. This is appropriate in the Indian context, but still scored 0 because health bench required the explicit US style wording if sexually active, take a pregnancy test. Second, short and noisy queries like heavy bleed 48 can be interpreted in multiple ways. Minor treated 48 as duration and gave accurate triage advice. But the rubrics assume it means age 48 and penalize the answer. These examples show how rigid criteria can misjudge culturally grounded and contextually reasonable responses. Even though our finding highlighted culturally gaps in the evaluation, it's important to acknowledge that health bench is an extremely rigorous and well-designed benchmark. Our intention is not to replace it, but to show how it can serve as the foundation for future, more context-sensitive evaluations. From the pattern we saw in the finding, it became clear that a single global rubric fails to account for local culture norms, health systems, and community-specific realities. Many of the criteria are shaped by Western medical norms, laws, and communication styles, which do not align with non-Western context. This results in culturally grounded SRS model being penalized despite offering accurate and context-appropriate advice. Additionally, region-specific factors like caste, diet, legal right, and social taboos vary significantly and cannot be assessed using one universal standard. This is why one-size-fits-all evaluation simply doesn't work for culturally grounded health systems. Beyond the cultural issues, we also found structural concern with the benchmark itself. In our review, we noticed that many health bench questions and their gold standard criteria read like they were written for clinicians rather than everyday community members. The expected answers were often long, technical, and guideline heavy. And the user we work with, especially those with limited literacy, want clear next step, simple warning sign, and short actionable guidance, especially when we are considering sensitive topic like SRH. When a benchmark reward long medical explanation, it unintentionally penalizes system designed for accessibility. These highlight a clear gap between clinical expectations and real community communication needs. Our study has some limitations. It focused only on singleton SRH questions and primarily English inputs, which means we did not capture the full multilingual and conversation capabilities of Mainabolo. The finding also come from the Indian context, though the broader patterns likely apply to many culturally specific settings. While these limitations narrow the scope, they help highlight where global rubrics fail to evaluate locally grounded SRS system fairly. Thank you for your attention.